psychiatric literature or the psychiatric guidelines are that if they're there for something else, like if they're there for their gallbladder being taken out and they happen to withdraw, you put them on methadone. But if they're there to withdraw and get off heroin, or they're there being treated for dependence and withdrawal, then you treat them symptomatically. I don't think they'll give you a question that asks you to tease apart those intricacies. Okay, so more people on fun substances. Now we've got a patient with horizontal nystagmus, dilated pupils, ataxia, and acute psychosis. Yeah, it sounds like PCP. So the nystagmus gives it away. Dilated pupils could be a lot of things. Could be cocaine, amphetamines, but if they've got nystagmus, think about PCP. And these people tend to be psychotic, so remember your haloperidol. If the patient presents after a motor vehicle collision, they've got injected conjunctiva, sedated, and they're asking for Doritos. Yes, good job. Patient presents with suicidal ideation, hypersomnia, depression, and anergia. Cocaine withdrawal. Very good. Patient presents with dilated pupils, seizure, tachycardia, and hypertension. Ooh, that's good. What if I told you they're intoxicated with something? Cocaine or amphetamines is what I was going for, but you guys gave valid answers from what I said. What's our best first test for cocaine or amphetamine intoxication? Good. We need a urine toxin to diagnose it, but if they're coming in intoxicated, remember, we got to look at what's going to kill the patient first. And people with cocaine or amphetamine intoxication can have arrhythmias, so it's good to do an EKG first, and then we confirm that they're on drugs. So if they have a seizure, because seizures can be an effective intoxication, you can treat that with a benzo. But how do we treat hypertension in someone who's on cocaine? We don't. We avoid beta blockers for sure, because these peeps who are taking cocaine, right, they've got norepinephrine out the wazoo. So if we give them a drug that blocks all the beta receptors, where's it going to go? Alpha receptors, and they're going to get hypertensive crisis, stroke, and death. So no beta blockers for people on cocaine. Treat them with something else. Calcium channel blockers, maybe an alpha blocker or something else, but not beta blocker. Okay, so childhood development. I'm going to go kind of fast here, but make sure you look at it. Let me just put them all up. We'll talk about the big ones. Oh, no. Okay, so I think the ones that I remember seeing most often were the Piaget, the Erickson conflicts. I don't remember seeing that, but it's in all of the books. When you start reading about child psych, it always starts with these childhood development things. What I would remember is the time when death is permanent is usually 6 to 7 years. That's where the concrete operational phase starts. And the ability to think abstractly begins at age 11. That's when formal operational starts. So the difference between pre-operational, concrete operational, and formal operational, I remember being important on my shelf. But this stuff is in all the child psych books, so I figured I'd throw it up here. Okay, let's do a question. An 11-year-old boy is evaluated for developmental delay, poor school and social performance. Formal IQ testing reveals his IQ to be 50. He has macrocephaly, long face, and macroorchidism. What degree of mental retardation does he have? Moderate. So remember, what's the average IQ? And what's the standard deviation? 15. So average IQ is 100, standard deviation is 15. And at 2 standard deviations below, that's the upper limit of mild. And then it's in 15 increments. So 70 to 55 is mild, 55 to 40 is moderate, 40 to 25 is severe, and below 25 is profound. Those are important numbers to remember. Where does this go on the DSM-4? Axis 2, very good, with the personality disorders, right? Personality disorders and mental retardation go in axis 2. And the most likely cause in this kid's case? Fragile X, very good. So remember, this is X-linked. It's one of the tricyclic repeat disorders, and it anticipates, which means it gets worse as the generations progress. And it's the most common cause of inherited mental retardation. It's more common than Down syndrome in terms of inherited mental retardation. Okay, so what about our newborn baby? Decreased tone, oblique palpebral fissures, simian crease, big tongue, white spots on his iris. What does that sound like? Downs. What are the white spots on the iris called? 10 bonus points. Brush field spots. Who cares? Okay, so this is Down syndrome. What can we tell his mom about his expected IQ? What range of mental retardation does Down syndrome have on average? It's usually mild to moderate. So it's typically not severe or profound, although it's not out of the realm of possibility. And she should expect delay in most of his developmental milestones. In terms of common medical complications, again, here are the medical questions they can ask you in psychiatry. What happens to the heart? Very good. Endocardial cushion defects is the most common cardiovascular abnormality. GI? Duodenal atresia, Hirschsprung's, and perforated anus, annular pancreas, which causes the obstruction in the intestine as well. Endocrine abnormalities? Similar to lithium? Good. Hypothyroidism. Musculoskeletal problems. This one's kind of random. They can have atlantoaxial instability, which is important to know if you're going to intubate them, like in anesthesia. Neurological problems. They get what kind of dementia early? Alzheimer's because of APP on chromosome 21. And any cancer risk increased for them? Oh, this was on step 1. You guys should know this. ALL. They have a 10 times increased risk of ALL. Okay. So more medical causes of mental retardation. This was the hardest part of child psych for me, just because there's a lot of details to keep straight. So if you see in the vignette, cafe au lait spot, seizures, big head, and it's an autosomal dominant trait. Neurofibromatosis. If there are coarse facies, short stature, cloudy cornea, autosomal recessive. This is biochem biting us in the butt right here. Very good, hurlers. 10 bonus points for you. Broad square face, short stature, self-injurious behavior, and it's caused by a deletion in chromosome 17. Kind of a random one. Smith-McGinnis. It was in the child psych book. I'm sorry. This is in Lang. These I read. The child psych book that I read was Lang. Okay, hypotonia, hypogonadism, hyperphagia, skin picking, aggression, and the deletion is on parental chromosome 15. Prader-Willi, seizure, strabismus, sociable with episodic laughter, much like a happy puppet, deletion on maternal chromosome 15. Angelman, elfin appearance, friendly, increased empathy, verbal reasoning ability, deletion on chromosome 7. Williams, oh, you guys are good. ADHD-like symptoms, macrocephaly, smooth philtrum, most common cause of mental retardation. Very good. Fetal alcohol syndrome. Seizures, chorioretinitis, hearing impairment, periventricular calcifications, petechiae at birth, and hepatitis. It's one of the torch infections, CMV. Seizures, hearing impairment, cloudy cornea, retinitis, heart defects, and low birth weight. Another torch infection. Rubella. Abnormal muscle tone, unsteady gait, seizures, mental retardation, or learning disability. I don't even remember what this one is. Oh, cerebral palsy. So remember, birth asphyxia or birth trauma, birth problems can cause hypoxia. And that's actually a very common cause of both behavioral problems, learning disabilities, and mental retardation in children. So these are all signs of upper motor neuron type problems with the contraction, unsteady gait, abnormal tone. Okay, what about this little friend? Intrauterine growth restriction, hypertonia, distinctive facies that I've got on the PowerPoint, limb malformation, self-injurious behavior, and they're hyperactive. I saw a kid like this in child psych clinic. Cornelia de Lange. Coloboma, oh, so this is an association, that's charge. The charge association is also, has mental retardation associated with it. Autism spectrum, and the rest of these with a chromosome 22 deletion. DeGeorge, vomiting, seizures, lethargy, coma, acidosis with stress. Sounds like biochem again.
Have they officially combined the diagnosis with vitellocardial facial?
I think they're interchangeable, last I remember from pediatrics, but I don't know. So, oh, this is annoying. All right, so exclusively in girls, hand-wringing, X-linked dominant. Tourette's, good. Normal development until age 2, then a major loss of verbal, social skills with autistic-like behavior. Good. So it's childhood disintegrative disorder because they lose milestones. So normal development and then regression. Lack of mother-child eye contact, language delay, and repetitive language. They're preoccupied with parts of toys like the little wheel that spins, and it occurs before age 3. Good. Autism. Problems with social skills, usually not recognized till preschool, but they've got preserved, not reserved, preserved verbal ability. That's Asperger's. Okay, good. You'll see a question on that in terms of developmental problems. So we've got a 7-year-old boy brought in by his parents, report that he must be told several times to complete his chores. They cannot get him to focus on completing his homework. He's easily distracted, and he often loses his shoes, pencils, books, etc. Do we have enough to diagnose ADHD? The way I asked it, right? Loaded question. So that's the hardest part about these questions, is you'll always see ADHD as an answer choice, and another answer choice will be normal age-appropriate behavior. So that's the hardest distinction to figure out. So do we have enough to diagnose ADHD here? Do we know anything about how he is at school? We don't, right? So here we just see that he's meeting some of the criteria, but only in one setting. We need 2 settings to diagnose ADHD. So diagnosis, as of now, normal age-appropriate behavior. We don't have enough to diagnose ADHD. Next best step, let's see how he does at school. Because if he's just exhibiting these same types of symptoms in the school environment, we might have enough for diagnosis. Risk factors for ADHD? It's heritable, so family history plays a role. Also, low birth weight babies tend to have more ADHD. Tobacco and ethanol use in utero leads to ADHD. Comorbid conditions with ADHD? Learning disabilities, true, and ODD and CD later on. That's the more common comorbid condition. And then treatment, all these drugs, right? So methylphenidate, amphetamines, amoxicillin, Strattera, and then there are some randoms. So here they are. Methylphenidate is like Concerta or Ritalin, and it works by blocking dopamine reuptake. The side effects for this and for Adderall and other amphetamines are decreased appetite, increased heart rate and blood pressure, anything you would expect from an amphetamine. The mechanism of Adderall is only different in that it also blocks norepinephrine reuptake and stimulates release. So just like the mechanism of action of the drug, or like cocaine. Atomoxetine is a newer drug. It's a norepinephrine reuptake inhibitor, and it's the only one that's a non-stimulant. But it still does cause dry mouth and insomnia, and will decrease appetite a little bit. But it has less of the problems like with the teenagers selling their Ritalin on the street. So that's what atomoxetine is good for as far as I've been able to tell. Some blood pressure medications can be used for ADHD, but this is like 3rd or 4th line, clonidine or guaifenesin. And they've got the side effects of clonidine and guaifenesin. And some antidepressants can help, again, by preventing reuptake. It's preserving more norepinephrine, but they're the same side effects as when these drugs are used as antidepressants. So, only a couple more slides. A 14-year-old boy is sent for court-mandated counseling. He stole his neighbor's lawnmower and then set fire to his tool shed. It's a nice kid. He has a 5-year history of truancy from school and assaulted a 13-year-old schoolmate. What does this kid have? Conduct disorder. Very good. So remember, the timing here is important. They need symptoms for 6 months. Look out for comorbid substance abuse in these children, and look out for them to progress to antisocial personality disorder. Our second patient, a 14-year-old boy brought in by his grandmother. For the past year, he's been getting into trouble at school for being argumentative, disrespectful, defies the rules that she sets for him in the house, and often deliberately annoys her. ODD, so oppositional defiant disorder. So this is another one that can be a little bit tricky between age-appropriate behavior and ODD. because all teenagers are a little bit a pain in the butt. Deliberately annoying, this kind of pervasive disrespect for rules and guidelines in multiple settings are things to tip you off. But if it sounds really, really mild, like the kid doesn't want to clean his room, or he talks back, or doesn't pick up his stuff, look for the answer choice normal age-appropriate behavior, and that could be right if you don't have enough of the diagnostic criteria to diagnose ODD. Okay, so a few more. A 9-year-old boy is sent to counseling at the recommendation of his teacher. She states that at least once a day he makes loud grunting noises and hand movements that are disruptive to class. What's that? Tourette's, very good. To call them Tourette's in contrast to just tics, they've got to happen fairly frequently. DSM-4 says at least once a day for a year, with no tic-free period lasting longer than 3 months to meet full diagnostic criteria. Comorbid conditions we talked about already. They're more likely to develop OCD. And treatment here, it's tricky because there's a difference whether they ask you for first line or they ask you for most effective. Most effective is haloperidol. That's definitely the most effective treatment. First line is actually clonidine because it's got a more favorable side effect profile. So read the question very carefully. Okay, 7-year-old, frequent abdominal pain, misses a lot of school, never gets the pain on the weekends or the summer. Separation anxiety. 6-year-old adopted child brought in because she's not formed a relationship with her adoptive parents. She's inhibited and hypervigilant. It's a reactive attachment disorder. So it usually happens with problems in early infancy where the patient or the child doesn't have their needs met consistently by the caregiver. 18-month-old baby recently regurgitating and rechewing her food, has previously been eating normally. There was a pretest question on this that I missed, so I put it in here. It's called rumination disorder, very good. And you check the lead levels because they usually eat random stuff too with the pica, so they are prone to lead poisoning. Okay, so we've got a 6-year-old, stools in her clothes once every 2 weeks. Next best test for her. What's a common medical cause of inocuparesis? Constipation. So we want to check for fecal retention there because it could be leakage of the diarrhea around the impacted stool. And the treatment, once we've ruled out medical causes, behavioral modification, but only rewards. You never want to punish a child for stooling inappropriately because that can lead to, if you believe Freud, can lead to some anal retentive tendencies in adults. So 6-year-old who urinates in her clothes once a day at nighttime. Next best test. So that'd be diagnosis. What do we want to rule out medically? UTI. So we want to make sure she doesn't have a UTI, and then we treat with behavioral therapy. The alarm pad works, and then there are some drug therapies you can use if behavioral modification doesn't help. And that's it. So we got it all done in 2 hours. Thanks for sticking around. Hopefully it was helpful. And I wish you guys the best of luck on your shelf exam on Friday. Thanks. Stick around if you have questions.